Next, we will hear from Dr. Ken Duckworth, the Blue Cross Blue Shield of Massachusetts Medical Director for Behavioral Health. In this role, Ken leads Blue Cross's strategic efforts in the areas of mental health and substance use disorders. He previously served as both the Chief Medical Officer and Acting Commissioner for the Massachusetts Department of Mental Health, and as part of his role at Blue Cross, he volunteers to see patients in the Department of Health's Early Psychosis Program at the Massachusetts Mental Health Center. He's trained in adult and child and adolescent psychiatry and is an assistant professor of psychiatry at Harvard Medical School. Blue Cross Blue Shield of Massachusetts created groundbreaking programs that expand access to care for people with opioid use disorder and provide education and other resources to reduce the stigma associated with opioid use. Their innovative efforts have inspired actions by other stakeholders across the country, and they were recently recognized for their community-wide approach to combat the opioid epidemic with a prestigious award from the Blue Cross Blue Shield Association. Ken has been leading many of these efforts, and we're so grateful that he's here with us today to share this work. Ken?
Good afternoon, and thank you for having me as part of this important conversation. So just a little more background on myself. I'm a child psychiatrist, adult psychiatrist, and I have done work in addictions and in the population with serious and persistent mental illness and community mental health. And I prescribed Suboxone for years as part of a dual diagnosis treatment team. I've then gravitated to policy discussions and jobs because I think there's a lot that can be done on the system level. And so I joined Blue Cross Blue Shield of Massachusetts, which as a provider I felt was a very progressive health plan, and I was delighted to join the team. Since I've been at Blue Cross, I've been trying to work the problem of making access to treatment for opiate use disorder and access to treatment for mental health disorders, which are commonly co-occurring, a big part of my role. I want to take a minute to tell you a little bit about Blue Cross Blue Shield of Massachusetts. So we're a health plan, it's a nonprofit. We're based in Massachusetts. We have about 3 million members through a variety of accounts across the state. And of the 3 million people, about 1 million of our people that we insure live in other states. So if you took a job with a company that was based in Boston, for example, and they had a satellite office in Boise, Idaho, we would be providing the benefits for the individuals who happen to have the plan in Idaho. So it's mostly Massachusetts, and I've traveled my whole career in Massachusetts, but I do want to emphasize that some of our policies do have impacts on people in other states. So I'd like to take your attention to the first slide, which is the Blue Cross Blue Shield Massachusetts public health approach to the crisis. And I think this will echo what you've already heard. We frame it slightly differently, but I think in essence, we're trying to work to row the boat in the exact same direction. On the prevention side, Blue Cross Blue Shield of Massachusetts was very early to the conversation of making it difficult to overprescribe opiates. This was in about 2011, 2012. And I want to emphasize that this was not greeted with cheers. We were very early on to take a look at how the health plan, as part of the ecosystem, could reduce overprescribing. And we went through a process with physician groups and physician leaders, and they got on board. And we had made some decisions to make it difficult to prescribe more than 14 days of an opiate, to make it very difficult to prescribe a long-acting opiate. We exempted categories of prescribers, such as oncologists and a few other subspecialties, just to make it clear that we do appreciate some people actually need opiates, but the idea that there was many extra pills floating around which were ending up in medicine cabinets and causing vulnerabilities was well known to us. Briefly, the governor of Massachusetts signed into law A few years after we started this initiative, an even more restrictive idea, limiting prescribing to 7 days. And for our own data only at Blue Cross Blue Shield of Massachusetts, we reduced over 20 million doses of opiates compared to the same amount in prior years. And that's simply from working with the professional societies and placing some corridors on how much you could prescribe without talking to us. And this is the traditional use of a utilization management tool that I think, was one of the initiatives to curb overprescribing. We are, of course, still evaluating every other option on the pain management scale because it's difficult to take a tool away from a physician who wants to do good for people. You have to really think comprehensively about the other alternatives. So it's a pretty long list from lidocaine patches to TENS units to Neurontin. It's a fairly long list, and we did a review of all of our treatments, making sure that it was easy to access these other treatments, that the copays were sensible, and that our policies were engaged in a way that we weren't simply making it difficult to access a pain treatment. We were trying to provide sensible alternatives. We're actively reviewing acupuncture to be a possible benefit right now. The literature on acupuncture is not as overwhelmingly clear as it could be. However, there are some studies that are indicative that it may be of import for some people to provide an alternative to pain. And I do want to mention, outside of the traditional roles of the health plan, we've invested in a program in the community called Drug Story Theater. This is all on the prevention idea. These are people who aren't Blue Cross Blue Shield of Massachusetts members. These are middle schoolers. And a brilliant child psychiatrist named Joe Schrand, who was on the show Zoom on PBS, some of you may recall, he developed a psychodrama theater program where kids in recovery get on a stage and do a presentation to middle schoolers throughout many communities here in Massachusetts, and then they take questions from the audience. And the program is poignant and compelling and has some data that kids appreciate, that certain things are addictive, that certain things require early intervention, and that certain things require conversations with parents. So that's in the prevention space. This is what our health plan has done. And as was stated earlier, I want to emphasize the health plan is one piece of the ecosystem, but I think if we're all rowing the boat in the same direction, we're going to have a better chance together as a society to end this crisis. Intervention is how we think of the use of Narcan. I was visiting family in Philadelphia perhaps a year or two ago, and I read an article in the Philadelphia Inquirer that librarians in Philadelphia were reversing overdoses because Philadelphia has had a particularly compelling strain of heroin, and many people were traveling to Philadelphia, it reported in the story, and ending up in the bathrooms of the public library. I reflected on this and realized that I worked for a very progressive health plan that would work with many ideas that I would put forth. And I said, I'd like to really take a look at how we're addressing Narcan as a benefit and what we could do to get more Narcan out there. So the first thing we did was we reviewed the copays for Narcan. And I will just say for Blue Cross Blue Shield employees, I have insurance through my job, like most Americans. My copay was $50. We reduced that to $0. And most people don't know that you can go to any pharmacy in America without an order from your doctor. You don't have to ask. There's no administrative burden. You can simply get Narcan. And in Massachusetts, the pharmacist is supposed to give you a 5-minute training. I was not giving any training, but I happen to be a physician who has administered Narcan in my day. So it occurred to me that if you got it to $0 copay and you structured a way to train people to administer Narcan, that we could increase the amount of Narcan in the commercial space. Then it occurred to me that we could work with creative employer groups. Many of you know the construction industry has very high rates of opiate use disorder and overdose deaths. The construction industry in Massachusetts has been very hard hit by that. And we approached several of our accounts in this space, and they were incredibly interested in teaching the foremen on their construction sites and their employees how to use Narcan. So we created a Narcan toolkit, which I'll show you in a future slide. We also did it to some of the towns of cities of Massachusetts. And these have been hard-hit rural communities and communities that are really trying to figure out, you know, if you had Narcan in your libraries, where you have public bathrooms, if you had it in municipal buildings, you had more people trained, there could be an improved access to treatment and also an awareness and consciousness. One of the things we also did is we showed the toolkit to our Blue Cross Blue Shield of Massachusetts employees. So let's say we have about 3,000 employees. We thought we would have 4 small sessions of 25 or so people. We don't have public restrooms. We don't have construction industries. So 2 of the best use cases for Narcan would not seem to be apparent for Blue Cross Blue Shield of Massachusetts employees. But we wanted them to know what we were doing with the construction industry and with the cities of and towns of Massachusetts. And we were impressed that 300 people came. We had to keep rerunning the sessions because people wanted to know what we were doing. They had heard that our organization had been a progressive leader in this field, and we had not won that award that you mentioned from Blue Cross. People did have a sense that we had some nice momentum going, but many people wanted to get trained for people that they loved. And I was very moved by this, the idea that office workers, you know, were living with people or loving people who had an opiate use vulnerability, and they wanted to be prepared to use Narcan. So that program has been well received, and with the copay of $0 for Narcan, we are seeing a substantial increase in utilization. When I talked to the company that makes Narcan, Adapt Pharmaceuticals, they described a phenomenon which I had never heard of, which was called medication abandonment, which is when people go to the pharmacy and ask for a medicine, they learn that the copay is too high and they leave the medicine there. And we, of course, have eliminated that problem by having a $0 copay. So for our fully insured and for our self-insured accounts, you know, you can get Narcan at no charge. I'm going to come back to that toolkit a little bit at the end, but I just want to go through what we've done on the treatment side. So we do think medication-assisted treatment is one, and not the only, essential element of treatment, and we've done a lot to advance the cause around medication-assisted treatment. We removed the copay and the deductible where allowed by law for methadone. And the use of methadone has gone up 5 times since we've made that change. I've spoken to several other health plans who are instituting methadone benefits. Methadone is not a benefit for every health plan across America. And it's just a good example that if you're giving a person a treatment every single day and you have a daily copay of $25, the cost becomes prohibitive quite quickly. We also eliminated the copay for Narcan. As I discussed, we've seen a substantial increase in utilization of that. And for Suboxone, we removed the prior authorization for 16 milligrams and under. So I happened to be at a substance use disorder clinician meeting when the email came through, and it's very rare in a health plan to have people hug you and cheer what you've done. And that was my experience that day because, you know, filling out paperwork and having a prior auth is a burden on providers, and we need the providers to take care of people. And we made a decision to remove that prior authorization. We also have an in-sourced behavioral health team at Blue Cross. So that means we have our own doctors, psychiatrists, psychologists, social workers, licensed mental health counselors. One of the things we do in treatment is we have relationships with all of the major detoxes here in Massachusetts, and our case managers know the people who run these detoxes, and we call and we say, is Ken there? We happen to have seen a claim that Ken has been admitted, and they'll say, well, let me see if I can get Ken on the phone. And the idea is that our relationship with the detox providers enables our members to speak to our case managers to see what we can do to promote their recovery. And what is the next step of care that they might need? What kind of supports might they want? Do they have a therapist? We removed all the paperwork burden for outpatient psychotherapy at Blue Cross Blue Shield of Massachusetts. And we've seen a substantial increase in the utilization of outpatient psychotherapy. Again, I see mental health and substance use disorder as frequently intertwined. So how we're thinking about our benefits on the mental health side impact people on the substance use disorder side. On the recovery side of the equation, of course, recovery is a process. It's individualized. For some people, it will involve work, family, faith. For other people, it may simply involve medication-assisted treatment. It's really different, I think, for each person. I've been very impressed by this. But one of the things we did is we gave $1 million of grants to 10 organizations across the state who have recovery coaches. We're trying to gather data. What have you learned from the recovery coaches that you have? How can you let us know how many people you can take care of? Are you following outcomes? How long do your recovery coaches stay in their job? What kind of continuity can people have with their experience? And we're doing this as part of a larger effort in Massachusetts to evaluate whether peer recovery coaches could be third-party reimbursable. I happen to sit on the Governor's Commission for peer recovery coaches, and we're actively trying to sort the questions of who could be a recovery coach and how could that be third-party reimbursed. Now remember, when you're a commercial health plan, you're spending other people's money. And when an account says, I'm writing this check to you to administer this benefit, they want to make sure that there'll be quality and safety that will be administered as part of that. So this is kind of how we're thinking about this in the Massachusetts Peer Recovery Coach Commission. Our grants from Blue Cross to the 10 organizations were an effort to gather data, but I think the larger question that we're facing with the workforce shortage that we have in Massachusetts, despite the fact that we have a large number of training programs in medicine, psychiatry, psychology, we produce a lot of clinicians. I mean, Boston is essentially, an academic center in medicine. But we still feel that we have a workforce shortage in terms of some specialized areas of care. And one of the ideas is, could peer recovery coaches supplement, not replace, the current system of care? And so we're actively looking at that piece of the equation. Just to take a look at the next slide, I just want to show you this little toolkit that we put together. Again, this idea was borrowed from librarians in Philadelphia. And, when an account came to us and said, we want to train our foremen or our librarians in our city of or town of, or for Blue Cross employees themselves, this toolkit opens up. It's a size of a kind of a makeup kit, I think is a reasonable comparison. It has 2 doses of Narcan, information on how to identify someone who is overdosed. Obviously, to call 911, we are not trying to replace the highly functional emergency medical system. We're trying to supplement it. And some basic information on how to administer Narcan. So we've hired people from the Department of Public Health's overdose response team to train our accounts in this pilot. And to look at the next slide, we've also created a website for people who want to gather more information about their benefits at Blue Cross, what residential and inpatient programs are in network. It's virtually everything in the state, but people want to know, where do I go, where do I turn to? And we have the video from the Adapt Pharma on how to administer Narcan. Because again, I was impressed when I went to my local pharmacy that I did not get trained to use Narcan, and we thought it was important to put this out there. This website is publicly available. There's no, need to be a Blue Cross member, and I encourage you to take a look at it, take from it what you think is valuable, amend it for your own purposes. There's no intellectual copyright here. We're all trying to advance the ball on this important public health problem. So I'm going to stop there. Again, I just want to say the health plan is one part of the ecosystem. I'm interested in the audience's thought about other things we could do. I think we're pretty actively reviewing what we have, how we're trying to advance the ball as a community, but I'm always open to learning, and I want to thank you for your attention, and I want to thank this organization for putting together this important talk and for inviting me. Thank you.